Okay, let's unpack this. We live in a world where information, well, it just bombards us constantly, doesn't it? Especially when it comes to something as vital as healthcare. It can feel like you're trying to drink from a fire hose, really, when all you need is just a clear, concise understanding. Here at the Deep Dive, our mission is to be that precise shortcut. We want to help you not just understand, but truly master complex, vital topics. So you can approach them like, well, like an elite professional in the field. Today, we're taking a deep dive into the very fabric of modern healthcare. We're going to explore this huge shift towards patient-centered care, the absolutely crucial role of cultural competence in, our rapidly diversifying world, and how these profound transformations are reshaping a critical and often high-stakes field like nurse anesthesia. This isn't just about understanding the latest medical advancements, though that's important too. It's about deeply understanding the fundamental forces influencing the quality of care you, or perhaps someone you love, might receive. It's really about gaining a truly holistic perspective on what defines high-quality, equitable care today.
And what's fascinating here is the sheer breadth and depth of our source material. We've pulled from foundational expert recommendations, some groundbreaking research, and really detailed analyses of current practices. This comprehensive approach lets us not just scratch the surface, but to, well, truly understand the nuances of this ongoing paradigm shift. Our mission, as you said, is to distill these insights so that you, our listener, can walk away with a level of understanding that truly equips you to be a well-informed professional or just a well-informed individual in this incredibly important area.
Okay, let's start at the beginning then. Let's look at this fundamental shift that is completely redefining how healthcare is delivered. For decades, the system largely operated from what's often called a paternalistic provider-centered approach. You think about it. The doctor or the healthcare provider, they were seen as the sole authority, right? The one who knew best. And the patient's role was largely just to, well, follow instructions.
Yeah, a passive role, really.
Yeah, exactly. But a series of landmark recommendations, particularly from organizations like the National Academy of Medicine, which people might remember as the Institute of Medicine, or IOM, they've profoundly challenged that traditional model. It feels like they almost demanded a revolution in care.
Precisely. And these reports from the National Academy of Medicine, they really didn't pull any punches. They laid bare several core critiques of the existing healthcare system. For instance, they stated very clearly that healthcare systems simply do not consistently provide high-quality care to all Americans. And that wasn't a minor oversight. It was identified as a pervasive systemic issue impacting millions.
Not just pockets here and there, but systemic.
Systemic, exactly. And beyond that, they found a persistent problem where critical medical knowledge, the latest advancements, weren't always translated into actual clinical practice efficiently. So what was known to be effective wasn't always what was actually being done at the bedside.
So the knowledge was there, perhaps in journals or conferences, but the application was lagging behind. Is that the idea?
That's it, exactly. It was a clear disconnect. They also pointed out that new technology, while often promising incredible breakthroughs, was frequently not applied safely or appropriately in practice, which, ironically, could lead to potential harm rather than the intended benefit. Not always, but the risk was there.
Right.
Yeah.
Using this shiny new tool without maybe fully understanding the implications for every patient type.
Correct. And finally, they highlighted that resources within healthcare were, and often still are, not utilized to their fullest potential. This leads to significant waste and inefficiency across the board. These were not small critiques. They painted a picture of a system in, frankly, dire need of transformation.
Here's where it gets really interesting, though, because these glaring issues, this stark reality identified by the National Academy of Medicine, didn't just lead to minor tweaks or adjustments. They fueled a monumental paradigm shift in how we think about care. It was a conscious, deliberate move away from that traditional provider-centric model, where the provider made all the decisions, to one where patients become active, empowered participants in their own care decisions. It's a fundamental rebalancing of power and responsibility, and frankly, it asks a lot more from both sides, doesn't it?
It really does. And this isn't just, a philosophical shift or a nice idea. It's backed by substantial and compelling research. Studies have consistently shown the proven benefits of this patient-centered approach across multiple dimensions. We're talking tangible improvement.
Like what specifically?
Well, tangible improvements in the care processes themselves, leading to more streamlined and effective interventions. It also results in more efficient utilization of healthcare resources, meaning less waste, more targeted care. And crucially, we see significantly higher patient satisfaction. Patients feel heard, respected, involved.
Which makes intuitive sense.
It does. And this also leads to enhanced patient self-management of their conditions, empowering them to take a more active role in their long-term health. And perhaps most profoundly, this approach has even been linked to, So it truly impacts the most vital outcomes for individuals. It's not just about feeling better, it's about being better, living longer.
That's a staggering impact. Linking better communication and involvement directly to actual mortality rates?
Yeah.
That's powerful. So for highly specialized professionals like anesthetists who are often dealing with patients at their most vulnerable, or just before or during a procedure, what does this new landscape mean for their day-to-day practice?
Yeah.
How does it change their role on the ground?
It fundamentally reshapes it. For anesthetists, the expectation is now firmly rooted in engaging patients throughout the entire perioperative period. This isn't just about, say, administering medication and monitoring vital signs, though that remains critical, obviously. It's about establishing a continuous, respectful dialogue from the moment they meet the patient to well after the procedure is complete. They're expected to explain choices clearly, understand patient preferences, provide emotional support. It's a much more holistic view. In this new paradigm, quality care is fundamentally a team activity. It emphasizes deep collaboration among all care providers, the surgeon, the nurses, the anesthetist. And crucially, the patient themselves is part of that team.
Really seeing the patient as an active team member.
Absolutely. Everyone has a role to play, and everyone's input is valued in ensuring the best possible outcome. It's a genuine partnership model.
Okay, shifting gears slightly, but it's deeply connected. Our deep dive now takes us to a critical and often uncomfortable truth about healthcare in the U.S., the persistent issue of health disparities. It's just impossible to truly discuss quality care or to understand the future direction of healthcare without directly addressing the fundamental inequities that, unfortunately, still exist within the system.
You're right. It's unavoidable if we're serious about quality. And to truly grasp the scope of this challenge, let's consider the striking demographic context of the United States. According to the U.S. 2018 census data, our nation comprises about 328 million people. But the racial and ethnic composition is far from uniform. White individuals make up about 76% of the population, Hispanic Latino around 18.5%, Black individuals 13.4%, Asian 5.9%, American Indian Alaskan Native or AIAN at 1.3%, and Pacific Islander 0.2%.
So a diverse picture already.
Very diverse. And what's critically important here isn't just that snapshot, but the projection from the Pew Research Center for 2050. They predict a dramatic demographic shift. Hispanic communities are projected to grow significantly, moving from a minority group to potentially comprising a substantial 31% of the U.S. population.
31%. That's a huge shift.
It is. And against this backdrop of increasing diversity, studies consistently reveal a disturbing pattern. Racial and ethnic minorities tend to receive poorer quality of care compared to non-minorities. This makes the active consideration and, more importantly, implementation of measures to reduce these disparities absolutely paramount for any healthcare professional. It's not just a social issue, it's a direct quality of care issue that impacts outcomes.
That's a powerful and deeply concerning demographic picture, especially the link to poorer quality of care. So let's specifically look at the nurse anesthesia community, which is such a vital part of our healthcare system. Does its composition actually reflect the diverse nation it serves? Are they, as a profession, prepared to serve this evolving demographic landscape?
Well, unfortunately, the data from the American Association of Nurse Anesthetists, AANA, 2018 Race and Ethnicity Profile Survey paints a very stark picture. They themselves describe it as an anemic racial and ethnic workforce within the profession.
Anemic, that's a strong word.
It is. The survey revealed that certified registered nurse anesthetists, CRNAs, are overwhelmingly white, about 89% of the profession. This is followed by Asian at 2.7%, Hispanic Latino 2.5%, Black at only 1.3%, Asian Pacific Islander lumped together at 2.7%, and AIAN at the 0.7%.
Only 1.3% Black CRNA.
Yes. It highlights a truly glaring disparity. I mean, think about it. Having only 1.3% Black CRNAs serving a growing and increasingly diverse population, many of whom are underserved, presents a significant disconnect. It suggests a lack of representation that can and often does impact trust, communication, and understanding in the patient-provider relationship.
And the COVID-19 pandemic threw a harsh, undeniable spotlight on these existing disparities, didn't it? It didn't necessarily create these problems, but it seemed to just exacerbate issues that were already simmering beneath the surface, exposing them for everyone to see.
It absolutely did. In 2020, the disproportionate impact of COVID-19 was starkly evident. The highest reported cases and death rates were concentrated among Hispanic and Black communities. And this wasn't just random chance or, genetics. It was intricately linked to underlying systemic structural barriers.
Oh, yes.
Things like pervasive issues with high unemployment rates, substandard housing conditions, geographic isolation limiting access to care, a persistent lack of access to comprehensive health care and insurance, and deep-seated inequities in education. Consider the very real, specific examples for American, Indian Alaskan, Native tribal communities. The CDC reported that geographic isolation combined with multi-generational households made it incredibly difficult for individuals in these communities to take precautions like social distancing or isolating the sick, especially in limited living spaces.
So the public health advice was almost impossible to follow for some.
Exactly. Public health emergencies, in essence, simply further diminish access to crucial resources for these groups, deepening their existing vulnerabilities and pushing them further to the brink.
Another tragic example that was brought to light in our sources, one that truly underscores these systemic issues, is the persistently high Black maternal mortality rates. What exactly do the sources tell us about this critical issue, and why is it so alarming?
This is indeed a critical issue. It demands immediate and sustained prioritization. Prior to COVID-19, Black maternal mortality rates were already the highest nationally, which is frankly a shameful statistic for a developed nation. A 2018 published article highlighted that Black women are significantly more likely to die than white women and experience higher case fatality rates from a range of conditions related to pregnancy and childbirth, even when the leading causes of maternal death for both Black and white women are similar.
So it's not just about different diseases, it's about different outcomes for the same issues.
Precisely. That strongly suggests systemic factors and biases at play rather than just underlying medical conditions. The alarming statistic from the CDC is that approximately 700 women die from complications related to pregnancy or childbirth every single year in the U.S., which tragically puts the U.S. at the top among developed nations for maternal mortality.
Leading the developed world in maternal deaths. That's shocking.
It is. And current COVID-19 data unfortunately suggests an increase in reported Black maternal mortality cases during this national crisis. It underscores how public health emergencies can mercilessly worsen existing inequities for vulnerable populations.
So when we look at these stark disparities, whether it's in the composition of the nurse anesthesia workforce or in patient outcomes like maternal mortality and the impact of COVID-19, it reveals a fundamental, undeniable truth. Structural institutional changes are profoundly needed across the board. It's not enough to just talk about individual care. The whole system needs to be re-engineered, doesn't it?
Absolutely. These disparities have profound implications, not just for individual patients, but for entire healthcare systems, for nursing and other healthcare professional associations, and critically, for colleges and universities in terms of how they educate and train a more robust and truly diverse workforce for the future. It's about recognizing that social determinants of health, or SDOH, those non-medical factors that profoundly influence health outcomes, play a very significant role in how people access and ultimately receive care.
Things like income, housing, education.
Exactly. All those things. This requires close attention to those underlying structural factors that actively contribute to poor health outcomes among ethnic populations. To truly reduce health disparities and inequities, we must address these root causes, not merely treat the symptoms. It's a holistic view of health that extends far beyond the clinic walls.
Okay, so we've established this critical need to improve health outcomes, especially for underserved populations, and the unfortunate persistence of disparities. A key strategy for addressing these issues and elevating care for all is patient-centered care. But what exactly does it mean in practice, and why is it so incredibly important right now, perhaps more than ever, to adopt this approach?
Well, there's a growing and undeniable demand coming from every direction. From patients themselves, absolutely, but also from policymakers, insurers, regulators, accrediting bodies, all pushing relentlessly for improved healthcare quality and safety. This demand isn't going away, and it requires professionals like anesthetists to persistently evaluate and elevate the quality of care they provide.
So pressure's on from multiple angles.
Definitely. And for this reason, patient-centered care is increasingly advocated as a key approach globally. It's quite simply considered the gold standard of healthcare delivery. It's recognized as an effective and highly efficient method. It has the potential to significantly improve quality, patient safety, and outcomes, both at the individual patient level and across broader system levels. And what's more, it's considered critical for reducing overall healthcare costs, by making care more targeted, preventing unnecessary interventions. It's a truly multifaceted solution.
It's interesting, though, the sources mentioned there's a lack of universal consensus on what precisely constitutes patient-centered care and how it should actually be delivered. How do we navigate that, given its proclaimed importance? Is it like we all agree it's good, but we define good differently?
That's a great way to put it. You're right. While the core concept is universally embraced, its precise definition and implementation can certainly vary depending on the context. However, most conceptualizations of patient-centered care share several common and crucial attributes. Think of them as a sort of foundational blueprint.
Okay, what are those common threads?
Well, they include emphasizing clear education and shared knowledge between providers and patients, actively involving family and friends in the care process, recognizing their vital support role, fostering deep collaboration and team management among all healthcare professionals involved, demonstrating genuine sensitivity to the non-medical, cultural, and spiritual dimensions of care, understanding that health is holistic, showing profound respect for patient needs and preferences, making sure their voice is heard, and finally, ensuring the free flow and accessibility of information, empowering the patient with knowledge.
So those are the general principles. Does the ANA have a more specific take for nurse anesthetists?
Yes, they do. The American Association of Nurse Anesthetists, or AANA, has a very specific and actionable definition they apply. For them, patient-centered care is based on the concept of shared decision-making. By establishing a patient partnership through sharing information and evidence, acknowledging patient preferences and ideas, identifying choices, and negotiating decisions and agreeing upon an action. Within this framework, CRNAs apply this by respectfully engaging patients in the design of a safe, high-quality anesthetic experience. They ensure the patient's ideas and preferences are genuinely heard and incorporated into the plan. It's a structured approach to that patient partnership.
Okay, that's clear. But it still seems like there's often a disconnect between the care patients expect and what they actually receive. Even with these high aspirations, that must be incredibly frustrating for patients, potentially leading to distrust or anxiety.
It absolutely is, and our sources highlight the significant gap. Patients frequently report substantial problems in, say, gaining access to critical information about their condition or treatment, truly understanding their treatment options, getting clear explanations regarding their medications, and receiving responsive, compassionate service from their providers.
So basic communication breakdowns, essentially.
Often, yes. And this lack of understanding, fear, and anxiety can have very real intangible impacts. For example, one study found that this specific lack of understanding, coupled with fear and anxiety about anesthesia, caused a staggering 1 in 4 patients to actually postpone their surgery.
1 in 4, that's huge.
It is huge. And this is particularly poignant when you consider the remarkable history of anesthesia safety. As we mentioned, we've seen an incredible 97% decrease in anesthesia-related deaths since the 1940s, dropping from 64 per 100,000 to just 1 per 100,000.
An amazing safety record.
Incredible. Yet, despite this safety record, the patient's emotional experience and understanding can still create significant barriers to receiving necessary care. It tells us that medical excellence isn't enough. The human element, the communication, the empathy is paramount.
So it's clear this isn't just an anecdotal idea, a nice to have. The concept of patient-centered care has a strong, identifiable research foundation underpinning its importance.
Absolutely. Most current conceptualizations of patient-centered care are directly built upon foundational research commissioned by the Picker Institute. They focus specifically on patient-centered care, conducting groundbreaking research that identified 8 key dimensions that truly define it.
Okay, what are those 8 dimensions?
They include respect for patients' preferences and values, providing emotional support, ensuring physical comfort, delivering clear information, communication, and education, ensuring continuity and smooth transitions of care, effective coordination of care among different providers, active involvement of family and friends, and finally, ease of access to care. This incredibly influential research directly shaped the landmark National Academy of Medicine report, which adopted these very categories. But crucially, it added additional layers of responsibility for health systems, explicitly linking overall healthcare quality to the successful implementation of patient-centered care. So it's a foundational pillar, not an optional extra.
So patient-centered care isn't just a desirable trait, it's considered one of the core foundational pillars of high-quality healthcare. It's non-negotiable, essentially.
That's absolutely right. The National Academy of Medicine defines 6 essential dimensions of high-quality healthcare: safety, timeliness, effectiveness, efficiency, equity, and patient-centeredness. And of these 6, patient-centered care is actually considered the most important dimension due to its very close association with patient safety. It underpins and often enables many other aspects of quality. Our sources detail 4 core concepts that truly embody patient-centered care, providing a kind of blueprint for action.
Let's hear them.
Okay. First is dignity and respect. This means anesthetists must actively listen to and respect the patient's point of view and choices. They need to proactively incorporate the patient's and family's knowledge, values, beliefs, and cultural backgrounds into the anesthesia plan. It's about tailoring care to the individual.
Truly seeing the patient as a whole person.
Exactly. Second is information sharing. Here, anesthetists are expected to communicate and share complete and unbiased information in a useful, affirming, timely, complete, and accurate way. The goal is to facilitate truly shared decision-making where the patient feels fully informed and empowered. Third is participation. This concept ensures that patients and their families are able to participate in decision-making at the level of their choice. Some patients want deep involvement, others prefer to defer more to the provider, and the system needs to respect and support both preferences.
Right, it's not forcing participation, but enabling it.
Precisely. And fourth is collaboration. This mandates that patients, families, healthcare professionals, and healthcare leaders collaborate on all aspects of healthcare, from direct care delivery at the bedside to the shaping of policy and professional education. It's a truly integrated, team-based approach, with the patient always at the center of that team.
This all sounds very noble and critically important for individual patient care, but how does it get translated into broader systemic goals? How does this philosophy move beyond the one-on-one interaction to influence entire healthcare systems, budgets, policies?
That's where frameworks like the Triple Aim, developed by Don Berwick and colleagues, come into play. It expands these patient-centered concepts to improve health outcomes on a grander, more systemic scale. The Triple Aim includes 3 core interconnected components. First, improving the patient experience, which encompasses both care quality and overall satisfaction. Second, improving the overall health of the population served, looking beyond individual encounters. And third, reducing per capita healthcare costs across the system, making it sustainable. These aims have been widely adopted by influential organizations like the Institute for Healthcare Improvement, IHI, and many others. They've become guiding principles for systemic change.
So better care, better health, lower cost. Sounds like the ideal.
That's the goal. The IHI's specific concept design for the Triple Aim further breaks it down into actionable areas. 1, a core focus on individuals and families, reinforcing patient-centeredness. 2, a fundamental redesign of primary care services and structures to make them more accessible and effective. 3, comprehensive population health management, thinking about community well-being. 4, establishing a robust cost control platform to ensure efficiency. And 5, ensuring seamless system integration and execution across all levels of care. Beyond these, other crucial components of patient-centered care identified in our sources include better coordination and integration of care across different providers, delivering truly holistic care that considers all aspects of a patient's life, fostering an enhanced provider-patient relationship built on trust, leveraging health information systems effectively, and critically, developing sociocultural competence among all providers, which we'll dive into more.
Okay, so the integration of patient-centered care isn't just about individual provider behavior changing. You're saying it's about a fundamental, deep-seated shift in organizational culture, right, from the very top down. What does it truly take for healthcare organizations, hospitals, clinics, entire health systems to embody this philosophy at every level? It sounds like a massive undertaking.
It absolutely is a massive undertaking. It requires a multifaceted approach at the organizational level. Our sources highlight 7 key factors that contribute to successful patient-centered care within an institution. You can think of it as a blueprint for cultural transformation.
Okay, 7 factors. Let's hear them.
First, leadership is paramount. CEOs, boards of directors, they must be fully committed and engaged, visibly championing and sustaining patient-centered care over the long term. If leadership isn't invested, it simply won't trickle down effectively.
Starts at the top.
Always. Second, there needs to be a clear and consistently communicated strategic vision and plan. This must be shared with all members of the organization, from administrative staff to frontline clinicians. Often, this vision should be visibly displayed in high-traffic areas. It serves as a constant reminder to providers of expected behaviors and, just as importantly, informs patients of what they can expect from their care. Third, there must be active involvement of patients and families at all levels. This goes beyond just individual care decisions. It means inviting patients to participate in key committees, helping design processes and services. Their lived experience is invaluable data.
Bringing the patient voice into the boardroom, essentially.
In a way, yes. Fourth, a supportive work environment for employees is essential. This includes actively engaging employees in all aspects of process design and treating them with dignity and respect. A stressed, undervalued workforce simply cannot consistently deliver patient-centered care. Their well-being directly impacts the quality of care they provide. Fifth, systematic measurement and feedback are crucial. Organizations must regularly monitor the impact of changes and interventions, collecting data to understand what's working, what needs adjustment. You really can't improve what you don't measure.
Data-driven improvement.
Exactly. Sixth, the quality of the built environment plays a role. Providing a supportive and nurturing physical environment, from comfortable waiting rooms to quiet recovery areas, is considered an integral part of patient-centeredness. It's about creating a healing space, not just a functional one. And finally, number 7 is supportive technology. Technology should engage patients and families by facilitating easy information access and seamless communication, rather than creating barriers. It should empower, not complicate. These 7 factors are really interlocked. True transformation requires all of them working together.
That makes sense. Beyond these internal organizational changes, though, how do policymakers actively drive and enforce the shift towards patient-centered care? What kind of leverage do they have to ensure these philosophies become widespread practice, not just something happening at a few model hospitals?
Policymakers utilize 3 main powerful drivers to encourage patient-centered care across the system. The first is mandatory government requirements for providers to collect and publicly publish patient experience data. This ensures transparency and accountability. If you know your scores will be public, you're more likely to focus on them.
Public reporting drives change.
It does. The second driver is making this information publicly available, which empowers consumers, patients to choose among service providers based on reported quality and patient experience scores. This creates a competitive incentive for quality. And the third driver involves financial incentives for providers who achieve high measures of patient-centeredness. This effectively ties financial rewards directly to quality outcomes pay for performance.
Follow the money.
Essentially, yes. For example, the Centers for Medicare and Medicaid Services, CMS, and the Agency for Healthcare Research and Quality, AHRQ, routinely collect data on patient experiences. This practice was significantly expanded and formalized by the Patient Protection and Affordable Care Act of 2010. CMS, in particular, provides financial incentives to healthcare providers and hospitals that provide information on quality, rewarding performance. To standardize this complex data collection, the Consumer Assessment of Healthcare Providers and Systems, CAHPS, developed standardized surveys. Hospitals use CAHPS to assess a range of crucial aspects: how well doctors communicate, how well nurses communicate, the responsiveness of hospital staff, clarity of communication about medicines, effectiveness of pain control, the cleanliness and quietness of the physical environment, and the clarity of discharge information given to patients. It's a pretty comprehensive look at the patient's journey through their eyes.
Okay, so a crucial strategy to truly implement patient-centered care, getting down to the actual interaction level, is patient engagement. What does that look like in practice, and how does it empower you, the patient, to take a more active role in your own health journey, moving beyond just being a passive recipient of care?
Patient engagement is defined as meaningful participation by patients in different aspects of care. This can range from direct clinical encounters with their doctor to contributing to the development of healthcare guidelines, or even participating in research studies. The dynamic here is crucial and truly transformative. The healthcare provider is the expert on medical care, offering their specialized knowledge and skills. While patients are explicitly recognized as the experts on their own life values and status, their preferences, their priorities, how health fits into their unique life circumstances, it's a partnership of different forms of expertise.
I like that, a partnership of expertise.
Exactly. For anesthetists specifically, the goal of patient engagement is to foster a strong patient anesthesia provider relationship. This is achieved through clear, empathetic communication, providing expert clinical guidance tailored to the individual, offering essential emotional support, and delivering personalized, tailored information. The specific components of patient engagement for anesthetists involve comprehensive education about their procedure and anesthesia options, thorough risk assessment explained in an understandable way, appropriate intervention based on patient input, ensuring ample opportunity for patient questions, creating a safe space for curiosity, and ultimately leading to shared decision-making.
Making sure the patient feels safe to ask anything.
Absolutely. This type of open and respectful communication empowers patients to participate fully, to ask questions without hesitation, and to express their feelings or concerns. And this, importantly, leads to better outcomes, not only through early risk identification, but, most critically, through genuinely shared decision-making that respects the patient's autonomy and values.
The way healthcare information is exchanged has also dramatically changed over the years, hasn't it? I mean, it's moved well beyond just face-to-face conversations in an exam room.
Indeed. Traditionally, healthcare information was almost exclusively exchanged in that face-to-face format, which limited accessibility and timeliness. However, modern health information technologies have dramatically altered this landscape, creating new avenues for engagement. We now see extensive use of e-health, which encompasses a wide range of digital tools, web-based interventions, smartphone apps that track health data or provide reminders, specialized equipment allowing remote monitoring.
All the tech we use daily.
Right. Telephone coaching has become a common and effective way to provide ongoing support and information, extending care beyond just the office visit. And of course, telehealth has rapidly expanded, allowing for remote consultations, virtual visits, and continuous care from practically anywhere. These technologies are fundamentally changing how information is accessed and exchanged, making it more accessible, timely, and convenient for patients, fitting perfectly into the patient-centered paradigm.
Another powerful tool mentioned in our sources is clinical decision support, or CDS. How does that fit into this evolving picture of patient-centered care and efficient practice, especially in a field like anesthesia?
Clinical decision support, or CDS, is a sophisticated process designed to provide timely, relevant information, usually right at the point of care. Its primary purpose is to assist in clinical decision-making for healthcare providers, staff, patients, or other individuals. It does this by bringing together relevant medical knowledge and person-specific information. As Greens defined it, CDS is the use of information and communication technologies to bring relevant knowledge to bear on the healthcare and well-being of a patient.
So using tech to get the right info at the right time.
Precisely. It's about leveraging technology to ensure the right information, whether it's the latest research, a patient's unique medical history, or maybe an alert about a potential drug interaction, is available precisely when and where it's needed most. Various CDS tools exist, tailored to different clinical needs. These include things like computerized alerts and reminders for providers and patients, integrated clinical guidelines that pop up at the relevant moment in the workflow, condition-specific order sets that streamline prescriptions and procedures, focused patient data reports and summaries that highlight key trends, documentation templates that ensure all necessary information is captured consistently, diagnostic support systems that might suggest potential diagnoses based on inputted symptoms, and contextually related reference information.
Lots of tools. How about specifically for anesthesia?
For anesthesia specifically, CDS tools are often characterized by their ability to 1. Enhance reimbursement or reduce costs by optimizing care pathways. 2. Increase adherence to critical clinical compliance or regulatory protocols. 3. Improve documentation accuracy, which is vital for legal and quality purposes. And 4. Monitor physiologic data in near real time during a procedure, providing intraoperative recommendations right there at the point of care. Research strongly reinforces the value of these tools in anesthesia, consistently showing that CDS improves both compliance with protocols and billing accuracy, making care safer and more efficient.
Okay, so as our patient population becomes increasingly diverse, as those demographic shifts we talked about continue, the concept of cultural competence moves from simply important to absolutely essential. What exactly does it involve for healthcare providers and for entire healthcare systems? It sounds like it's about far more than just language translation, though that's part of it.
You're absolutely right. It's profoundly more than just language, though language assistance is a key component, definitely. Both patients and healthcare providers are becoming increasingly diverse. This leads to more communities being bilingual or having significant numbers of residents with limited English proficiency or LEP. This reality means that nurse anesthetists, for instance, are becoming increasingly familiar with using language-specific print materials, multimedia resources, signage adapting their communication tools to meet diverse needs. Our sources highlight two foundational models that have fundamentally shaped our understanding and implementation of cultural competence, moving it from just a theoretical idea to an actionable framework.
Okay, what are those models?
The first is Campina-Bocote's, the process of cultural competence in the delivery of healthcare services. This model delineates 5 key constructs that healthcare providers must develop. First is cultural awareness. That's about deep self-examination, understanding one's own biases, assumptions, and cultural background, knowing yourself first.
Looking inward first.
That's exactly. Second is cultural knowledge, which involves gaining factual understanding of other cultures' health beliefs, practices, worldviews. Learning about others. Third is cultural skill. This is the practical ability to collect relevant cultural data from patients and conduct culturally sensitive assessments, tailoring questions, and communication style. Fourth is cultural encounters. This means direct engagement with diverse clients to refine existing beliefs and overcome prejudices, learning through real-world interaction, not just books. And fifth is cultural desire. This is the genuine motivation and commitment to engage in the entire process of cultural competence. You have to want to do it. A crucial aspect of this model is its emphasis that healthcare providers must see themselves as becoming culturally competent, rather than ever fully being so. It's a continuous, lifelong journey.
Not a destination, but a process.
Precisely. This ongoing process directly impacts the delivery of optimal healthcare. The second foundational model is the National CLS Standards, or Culturally and Linguistically Appropriate Services in Health and Healthcare. These were developed by the U.S. Department of Health and Human Services, HHS, Office of Minority Health back in 2000. Their purpose is to provide a comprehensive national structure for implementing culturally and linguistically appropriate services within organizations. The goal is improving their ability to effectively address healthcare disparities. The standards specifically highlight that language barriers, for instance, pose a significant problem for many racial and ethnic minorities seeking healthcare. This makes accessible professional language assistance a vital, non-negotiable component of quality, equitable care.
We touched on shared decision-making before, but how does it relate specifically to cultural competence and this broader concept of team-based care? It feels like they're deeply interconnected.
They are inextricably linked. Shared decision-making is reinforced as a pivotal strategy to improve patient engagement and serves as a vital healthcare quality tool. It's even used to examine variations in diagnostic procedures sometimes. It's fundamentally a collaborative process where an anesthesia provider and a patient, and often their family if they choose, work together to make the highest quality decision about the anesthesia plan, one that's truly best for that individual. This process is predicated on 3 essential pillars: access to evidence-based information about the risks and benefits of each option, the anesthetist's clinical experience and knowledge, offering expert guidance, and crucially, the patient's unique values and preferences, ensuring their individual needs are respected.
Evidence, experience, and values.
Right. And this concept has evolved to explicitly include interprofessional models of healthcare delivery, recognizing that modern healthcare is absolutely a team sport. Interprofessional care is defined as the development of a cohesive practice between professionals from different disciplines to provide an integrated and cohesive answer to the needs of the client and family. The benefits of this interprofessional model are significant and clear. It enhances communication among team members, which is vital for complex care. It increases patient safety by catching potential errors earlier. It improves job satisfaction for providers, fostering a more collaborative environment. And ultimately, it leads to better patient and process outcomes. The American Association of Nurse Anesthetists, the ANA, explicitly supports interprofessional collaboration, recognizing its critical importance for high-quality, patient-centered care.
Even with such clear benefits, though, there are still significant barriers to implementing shared decision-making consistently across the board. What are the main obstacles that providers and patients continue to face? Why is it so hard sometimes to get this right every time?
That's a crucial question, because despite the clear advantages, several significant barriers persist. A primary one is health literacy. This refers to the skills an individual needs to access, understand, and use health information to make an informed decision. Providers must constantly consider the patient's ability to truly understand and apply information, tailoring their approach accordingly, often needing to simplify complex medical jargon without being patronizing.
That's a tricky balance.
It is. Beyond that, a simple lack of familiarity and order experience with shared decision-making itself, both on the part of patients and providers, can be an obstacle. Sometimes, patients may simply lack the desire to participate actively in the process, preferring to defer completely to the provider, and that preference also must be respected. On the provider side, barriers can include a lack of up-to-date knowledge about evidence-based practice for all conditions they might encounter, limited access to necessary resources like easy-to-understand patient handouts, and significant time constraints in busy clinical settings that can push providers towards rushing decisions.
The pressure of the clock.
Exactly. Our sources also mention a potential financial disincentive for healthcare providers in a fee-for-service environment. Shared decision-making may in some cases lead to more conservative treatment choices and thus reduce the use of high-cost procedures, which can impact revenue streams. Furthermore, some providers may resist its full integration if they perceive it as interfering with their established workflow or their traditional sense of control over the care process. These are complex, multi-layered challenges that require systemic solutions, not just individual effort.
Okay, so now that we've explored the definitions and the complex integration of patient-centered care and cultural competence, let's zoom out again. Let's look at the wide-ranging, tangible benefits. This isn't just about a better experience, right? It's about better outcomes across the board for everyone involved in the healthcare ecosystem. What are these measurable benefits?
Exactly. The benefits are extensive. They encompass both clinical outcomes and operational efficiency. When patients and their families, providers, and administrators collaborate and partner effectively, we consistently see a measurable increase in both patient and provider satisfaction. That's key. This collaboration also leads to a boost in overall healthcare quality and safety, and critically, a measurable decrease in healthcare costs by optimizing resource use and preventing errors.
Better quality, better experience, lower costs, the triple aim we talked about.
Precisely. The list of specific positive outcomes associated with patient-centered care is compelling and impactful. It includes decreased mortality rates, fewer emergency department visits, a reduction in medication errors, lower infection rates, higher functional status for patients post-treatment, improved overall clinical care, and even an improved liability claims experience for healthcare organizations, highlighting its legal and financial benefits too. Patient-centered care also demonstrably improves efficiency through a reduction in unnecessary diagnostic tests, a decrease in unnecessary referrals, and lower hospital admission rates. Furthermore, the enhancement of patient satisfaction and trust directly correlates with improved provider satisfaction and, crucially, higher provider retention rates within healthcare systems, which creates a more stable, experienced, and content workforce. It truly creates a virtuous cycle when done right.
This leads us directly to that broader vision, often referred to as value-driven healthcare. What does that mean in the grand scheme of things, and how does it connect to everything we've been discussing, from patient engagement to cultural competence to these benefits?
Well, the pursuit of a high-value, high-quality healthcare system has seen extensive resources allocated at national, state, and local levels because it's a critical national priority. The Department of Health and Human Services, HHS for instance, is actively promoting patient-centered care as a core strategy to improve healthcare quality. One way they do this is by providing transparent information about local health providers, allowing patients to make informed choices based on value. At its heart, healthcare value is precisely defined as the healthcare outcomes achieved based on the dollars spent.
Outcomes per dollar.
Exactly. Its guiding mantra is profoundly simple, yet powerful. The right care for every person, every time. This means the core focus of value-driven healthcare is to consistently deliver care that is safe, effective, efficient, patient-centered, timely, and equitable. These are the very pillars we've been examining throughout our deep dive. It demonstrates how patient-centeredness isn't just a nice idea, but an integral component of the broader vision for a truly valuable and sustainable healthcare system. It's about getting the most health impact, the best outcomes for every healthcare dollar spent.
Okay, but despite all these concerted efforts towards patient-centered and value-driven care, the quality of healthcare in the United States continues to raise serious concerns, particularly regarding those persistent disparities we discussed earlier. Why do these gaps still exist, and what are their root causes, even with this significant philosophical shift and policy push? It feels like we should be further along.
It's a crucial question, and the answer is complex and, frankly, deeply frustrating. Even with significant efforts by organizations like the National Academy of Medicine and AHRQ to reduce health disparities, these gaps regrettably continue to persist. It's a stubborn problem. Populations may experience inequality in healthcare, decreased patient safety, and poor health outcomes based on the whole range of personal characteristics that should have absolutely nothing to do with their medical need. Things like race, ethnicity, socioeconomic status, language, gender, religion, immigrant and refugee status, disability, geography, insurance status, sexual orientation, the list goes on.
So many potential points of inequity.
Yes. The landmark National Academy of Medicine report, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, meticulously found something quite striking. It found that even when individuals had the same socioeconomic status and insurance, and even when comorbidities, stage of presentation, and other potential confounders were controlled for, minorities often received a lower quality of healthcare than their white counterparts. This really underscores that the root cause of health disparities is incredibly complex, multifactorial, and unfortunately deeply ingrained. It extends far beyond simple socioeconomic factors or insurance status.
Okay, let's unpack this further because understanding these root causes is absolutely key to finding sustainable solutions. The Unequal Treatment Report identified several specific areas where these disparities originate. Let's dig into those one by one.
Absolutely. The report pinpointed several critical areas that contribute to these persistent disparities. First, health system factors. These relate to the inherent complexity of the healthcare system itself. Just think about it. Minority patients, those with limited English proficiency, LEP, individuals with low health literacy, those with existing historical mistrust of the system, perhaps due to past injustices, and those with limited familiarity with complex healthcare processes. They often find it disproportionately difficult to navigate this labyrinthine system. The simple presence or absence of professional interpreter services for patients with LEP, for example, can be a monumental factor directly causing disparities in understanding and care outcomes.
Just navigating the bureaucracy can be a barrier.
A huge barrier. Second, care process variables. This category includes issues directly related to healthcare providers' communication and potential biases, both conscious and unconscious. This can subtly or overtly manifest as stereotyping of patients, which may then lead to differences in recommendations for treatment and diagnostic procedures. It also includes providers' limited skills in effectively communicating with diverse populations, perhaps not knowing how to engage with different cultural norms around health or decision-making. This inevitably impacts clinical decision-making and patient trust. And third, patient-level variables. These are factors stemming from the patient's side, but they are often heavily influenced by the systemic factors we just discussed. They include things like a patient's own difficulty navigating the healthcare system, that historical mistrust of healthcare providers we mentioned, sometimes refusal of certain services based on cultural beliefs or previous negative experiences, poor adherence to treatment plans, which can sometimes be due to lack of understanding or resources, not just unwillingness, difficulty voicing concerns and asking questions effectively, and tragic delays in seeking care until conditions become far more severe and difficult to treat. All these factors interact in complex, often insidious ways to perpetuate disparities.
Given these complex and deeply ingrained root causes, cultural competence truly emerges as a crucial, actionable strategy, doesn't it? Not just a desirable trait for individual providers, but essential for the whole system to adopt.
Absolutely. The cultural competence of healthcare providers and, more broadly, entire healthcare systems is a direct, actionable strategy to address these pervasive disparities and significantly improve outcomes. Culturally competent patient care, at its core, requires healthcare providers to be respectful and truly responsive to the health beliefs, practices, and needs of diverse populations. As healthcare systems are redesigned for patient-centered care, which is the goal we've been discussing, it becomes imperative that they must integrate cultural competence strategies at every level to truly achieve equity. We can think of this as fostering a genuine culture of equity.
A culture of equity. I like that framing.
And the benefits are manifold. Increased levels of cultural competency have the potential to dramatically improve patient-provider communications, leading to deeper trust and understanding. It can enhance the accuracy of diagnoses by enabling providers to gather more complete and contextually relevant information. It can prevent patients from exposure to unnecessary risk in diagnostic procedures by ensuring appropriate, culturally sensitive choices are made. It enables providers to better obtain truly informed consent, ensuring patients genuinely understand what they're agreeing to. And crucially, it empowers patients to fully participate in shared decision-making in a way that aligns with their values. Furthermore, cultural competency training has consistently been shown to improve the knowledge and attitudes of healthcare professionals who care for racial, ethnic, and linguistic minority patients, building essential skills and awareness that persist over time.
There seems to be a significant overlap between patient-centered care and cultural competence. Are they essentially the same thing, or are there distinct differences worth noting for our listeners who are really trying to master this?
That's an excellent and very important question, and it's key to truly mastering this topic. Both patient-centered care and cultural competence ultimately aim to improve healthcare quality. That's the shared goal. However, they emphasize slightly different, though complementary, aspects. The primary goal of the patient-centeredness movement has been to provide individualized care and restore an emphasis on personal relationships. It aims to elevate quality for all patients by tailoring care to their specific needs and preferences. Think of it as customizing care for you, the unique individual.
Focusing on the individual.
Right. Conversely, the primary aim of the cultural competence movement has been to increase health equity and reduce disparities by concentrating specifically on people of color and other historically disadvantaged populations. It recognizes and actively works to address the systemic barriers they face. Think of this as ensuring fairness and access for specific groups who have been marginalized.
Focusing on group equity.
Exactly. Nevertheless, there is significant common ground between the two movements. In effect, we can say that truly patient-centered care is inherently culturally competent because you can't be truly centered on a patient without understanding their cultural context, their beliefs, their values. And by the same token, truly culturally competent care is inherently patient-centered because it focuses on respecting the individual within their cultural framework. They're really two sides of the same coin, working in concert to achieve holistic, equitable, high-quality care for everyone.
Okay, that clarification helps. If we connect this to the bigger picture, then what specific actionable steps are involved in achieving true health equity and reducing disparities in the long term? Moving from these core concepts to sustainable practice across an entire system. Our sources outline 6 detailed steps from the Robert Wood Johnson Foundation. Let's break those down.
Yes, this is the roadmap for real sustainable change. The Robert Wood Johnson Foundation report outlined 6 detailed steps for long-term integration and sustainability in reducing disparities and improving equity. It provides a practical framework for healthcare leaders and professionals. First, it's about linking quality and equity. This means focusing on achieving optimal outcomes for all groups of patients, while recognizing that optimal outcomes may indeed differ from person to person based on their unique circumstances and values. It requires implementing a basic quality improvement infrastructure and then making equity an integral component of all quality improvement efforts. These efforts must be tailored to each specific patient population and specifically target the root causes of inequities identified. A vital part of this is the routine collection and analysis of healthcare process and demographic variables, things like race, ethnicity, and language preference, REL data. This data is absolutely crucial for identifying where disparities exist and for measuring progress over time. You need the data.
So you can't just aim for overall quality improvement. You have to break it down by group and target specific inequities revealed by the data.
Exactly. You have to disaggregate the data. Second, it's about creating a culture of equity. This literally means recognizing that disparities may exist in an organization and taking responsibility for reducing them. It depends on healthcare providers and staff acknowledging disparities, not being defensive about them, and committing to their reduction. This involves explicitly reflecting equity in organizational mission and vision statements, making it core to the identity. Practical examples include designating specific leaders responsible for disparities reduction, identifying equity champions who are passionate about tackling inequalities on the ground, actively recruiting and maintaining a diverse workforce that truly reflects the patient population served, creating and maintaining active patient community advisory boards that are representative, and fostering strong working and consulting relationships with community-based groups serving priority populations. It's about building a system that inherently values and pursues fairness. Third, we need to be effective at diagnosing the disparity. This requires that deep understanding of the social determinants of health, SDOH, which, as the WHO defines them, are the conditions in which people are born, grow, live, work, and age that impact their health.
So everything outside the clinic walls again.
Precisely. Where you live, your access to healthy food, your education, community safety, employment, these factors profoundly shape your life and, fundamentally, your health. Nurse anesthetists, like all nurses, need a comprehensive understanding of SDOH and their strong association with health outcomes to provide effective patient-centered care. For instance, we know chronic stress from factors like poverty, racism, inadequate housing, unemployment, food insecurity. It damages body systems over time and is directly linked to chronic disease and premature aging. Nurses can play a crucial role here by linking patients to needed resources, food banks, housing assistance, job training, assisting in program planning for community health initiatives, and advocating for system-level and policy changes. This often requires cross-sector collaboration reaching beyond traditional healthcare systems. This also includes understanding the powerful case for race-based disparities. We have to acknowledge that despite controlling for numerous confounders like socioeconomic status and insurance, health inequities among racial minorities are pronounced, persistent, and pervasive. The IOM's Unequal Treatment Report documented over 175 studies showing these disparities. Lack of insurance was a significant driver, but clearly not the only one. These disparities persist even among insured, higher-income minority patients, which is a truly alarming finding pointing towards systemic bias within the care process itself.
So it's about recognizing that a patient's health isn't just about their biology or lifestyle choices, but their entire lived experience in the societal structures they navigate every day.
Exactly. And fourth, it's critical to focus on increasing workforce diversity. National strategic plans are critically needed to increase the diversity of the healthcare professional workforce, including nurse anesthesia, as we saw with those ANA numbers. The current lack of diversity is a key barrier to a truly culturally competent system and diminishes our nation's capacity to eliminate disparities and advance health sciences equitably. This requires strategic recruitment and retention efforts for minority nurse anesthesia students, faculty, and clinical coordinators at the college and university institutional level. It needs dedicated resources. Moreover, increasing the number of minority nurses in influential leadership roles is vital, as they are often better positioned to directly influence resource allocation, recruitment retention practices, and shape organizational and national policies aimed at eliminating health disparities. That ANA 2018 survey showing only 1.3% Black CRNA serving growing diverse populations starkly magnifies this urgent need for representation at all levels. Fifth, once you diagnose the disparity and hopefully have a more diverse team thinking about it, it's about designing the intervention. Best practices must be used, naturally. Intervention should be multi-level, targeting multiple players within the healthcare system, individual providers, teams, departments, the organization as a whole, and crucially, they must be based on thorough root cause analysis findings, not just addressing superficial symptoms. Resources like the Finding Answers Intervention Research FER database exist to provide customized lists of evidence-based interventions that address specific diagnosed disparities.
So using evidence to tailor the solution.
Yes. Sixth, and this is truly fundamental, is securing buy-in. This is a critical component for success. It entails a strong, visible pledge of support and the provision of necessary resources from all stakeholders involved. That means hospital boards, administrators, clinical leaders, frontline staff, and even the community itself. Without this shared commitment and resource allocation, even the best designed interventions will falter or fail to be sustained. And finally, there's the ongoing process of implementing change. Once causes are analyzed, tailored interventions designed, and buy-in secured, a strong foundation for success is laid. The implementation process requires regular evaluation using three types of measures. Data evaluation process measures, are we doing what we said we'd do? Outcome measures, are we moving the needle on disparities? And intervention tracking, how is the intervention being adopted? The long-term goal here is sustainability, embedding these changes into the fabric of daily practice so it's not just a temporary project. The policy landscape is also actively driving this increased emphasis on cultural competence. This is spurred by the undeniable rise in minority populations across the U.S. The Patient Protection and Affordable Care Act, ACA, which significantly increased the number of newly insured individuals, bringing more diverse populations into the system. Broader ongoing healthcare reform efforts, growing findings on how sociocultural differences between patients and providers profoundly influence communication and decision-making, and that ongoing push for value-based healthcare, which ties reimbursement to quality and equity. The ACA, for instance, specifically addresses disparities through components like accountable care organizations, ACOs. ACOs aim to ensure patients receive the right care at the right time and prevent errors by coordinating care among groups of doctors and hospitals, with shared savings incentives often tied to quality metrics that include disparity reduction. Similarly, the HHS Disparities Action Plan is explicitly focused on achieving a nation free of disparities in health and healthcare, setting a clear national objective and strategic direction.
Okay, that's a comprehensive roadmap. To summarize this complex integration of patient-centered care and cultural competence, then what are the key features of a truly culturally competent healthcare system and effective interpersonal interactions that we as listeners should be looking for or striving to implement ourselves?
Our sources, specifically Table 3.2, neatly outline these critical features, serving as a comprehensive checklist for both systems and individuals. For culturally competent healthcare systems, they should demonstrably have a diverse workforce that truly reflects the patient population they serve at all levels. They must have robust, readily available professional language assistance for all patients with limited English proficiency, not just relying on family members. And they need to provide ongoing, meaningful training for all staff regarding culturally and linguistically appropriate services, making it a continuous learning process, not a one-off checkbox exercise.
And for the interactions between people.
Right, for culturally competent healthcare interpersonal interactions, that direct patient-provider relationship provider should actively explore and respectfully acknowledge the patient's unique values, preferences, and needs, always seeking to find common ground for shared decisions. They must also be acutely aware of their own biases and assumptions, constantly checking themselves, and keenly aware of existing health disparities and the potential for discrimination that patients may face or fear. And critically, they must effectively use professional interpreters as needed to ensure clear, accurate communication, bridging both linguistic and cultural divides effectively. The ultimate goal here really is not just tolerance, but a genuine embrace of the differences within our diverse populations, while simultaneously considering ways that we are all fundamentally the same human beings deserving of respect. It's about being deeply respectful of individual differences within cultural contexts. By actively designing services tailored to a patient's culture and language preference, health professionals can significantly help improve positive health outcomes for diverse populations, ensuring high-quality, equitable care for absolutely all. This is where true mastery lies, I think.
Okay, we've explored the what and why of patient-centered care and cultural competence in depth. Now, let's tie this all back to the bedrock. Safety and quality measurement, especially within a critical high-stakes field like anesthesia. And also, how all of this impacts the economic reality of healthcare delivery. Because at the end of the day, care has to be safe, high quality, and financially sustainable, right?
Absolutely. Patient safety is truly the absolute non-negotiable foundation of high-quality healthcare. Everything else builds on that. There's a growing recognition throughout the industry of the paramount importance of establishing and maintaining a robust culture of safety and quality. The Joint Commission, a leading accrediting body for healthcare organizations, defines a culture of safety as the summary of knowledge, attitudes, behaviors, and beliefs staff shares about the primary importance of the well-being and care of the patients they serve, supported by systems and structures that reinforce the focus on patient safety. Healthcare systems that successfully cultivate this culture of safety and provide high-quality care are typically guided by three core principles: trust among staff at all levels, fostering open reporting of errors or near misses without fear of reprisal so problems can surface, and a deep commitment to continuous improvement based on learning from those reports and insights. It's a perpetual cycle of vigilance and refinement.
While healthcare safety has significantly improved over the years, and anesthesia, as we mentioned earlier, has an incredible track record, there's always room for more improvement, and there are still ongoing challenges that require continuous vigilance. What's an example of an area where this improvement process is still keenly felt, and why is it so important?
A prime example of an ongoing challenge, one that directly impacts both patient outcomes and healthcare costs significantly, is surgical site infections, or SSIs. These are unfortunately one of the most common types of hospital-acquired infections, accounting for up to a staggering 40% of all such infections in some reports.
40%, that's almost half.
It's a huge number, and their impact is significant and multifaceted. SSIs dramatically increase the economic burden on the healthcare system by extending the length of hospital stay, sometimes doubling hospital costs for affected patients. They also lead to severe, potentially long-lasting disability-related outcomes for the patient. To combat this specific problem, the Surgical Care Improvement Project, SCIP, was launched some years ago by CMS and the CDC. It's specifically aimed to reduce various perioperative complications with a major focus on SSIs. This initiative mandated crucial actions, for instance, ensuring antibiotic prophylaxis is administered at precisely the right time, usually within an hour before the surgical incision, using the appropriate antibiotic for the specific procedure type, and discontinuing the antibiotic within 24 hours post-surgery to prevent antibiotic resistance. Simple, evidence-based steps.
Focused, concrete actions.
Right. And studies have indeed shown that SCIP has been successful in reducing infection rates overall, though compliance rates among hospitals can still vary. Some reports show ranges from 60% up to 100%. To encourage compliance, hospitals are given financial incentives and are required to audit and publicly release their SCIP data to both CMS and insurance companies, making the process transparent and holding them accountable. It's a clear example of how data, mandates, and incentives can drive real change in patient safety practices.
How is this critical culture of safety specifically fostered and implemented within nurse anesthesia practice, given their unique responsibilities and the direct nature of their patient interactions during vulnerable times?
Within nurse anesthesia practice, a strong culture of safety is explicitly supported by foundational documents like the AANA's Patient-Centered Peri-Anesthesia Communication Guidelines, which clearly elaborate on how patient-centered care directly contributes to safety. A literature review by Sammer and colleagues, aimed at developing a conceptual model of safety culture, identified 7 core components that significantly influence a patient's safety culture within healthcare settings. These act as pillars of excellence.
7 components again. Let's hear the safety culture.
Okay. First, leadership. Leaders align mission, vision, competencies, and resources across all staff levels, consistently setting the tone for safety from the top. Second, teamwork. This fosters collegiality, collaboration, cooperation, and crucially open, respectful communication among executives and staff, ensuring everyone feels safe to speak up. Third, an evidence-based approach. Patient care processes are standardized and grounded in the latest scientific evidence, reducing unnecessary variation and guesswork. Fourth, clear communication. All staff, regardless of their position or hierarchy, have the right and responsibility to advocate for the patient, ensuring concerns are heard and addressed promptly.
Empowering everyone on the team.
Exactly. Fifth, a culture of learning. Learning from mistakes is valued, and the facility actively strives for continuous performance improvement, viewing errors as opportunities for system growth rather than just individual blame. 6. A just culture. This recognizes that errors are often rooted in system failures rather than purely individual failures, while still holding individuals accountable for reckless actions. It's about fixing the system, not just blaming people. And finally, number 7, being truly patient-centered, meaning that care is focused on patients and their family caregivers, with patients actively participating in their care decisions, which enhances safety by catching potential misunderstandings or preferences early. These 7 components are interwoven, creating a robust safety net when implemented effectively.
Measuring quality in healthcare, especially in a complex and critical field like anesthesia, still sounds like a huge undertaking. How is it actually done, and why is understanding this measurement process so important for the future and sustainability of the profession itself?
It is indeed a monumental task, but absolutely vital for both patient well-being and the profession's future viability. The main goal of healthcare quality improvement is, fundamentally, to identify and continue what works well within the present system, while simultaneously focusing intensely on improving areas that need it. Historically, defining the precise importance or relevance of any given quality measure was problematic, sometimes leading to confusion or focusing on the wrong things. This is where the National Quality Strategy, NQS, established by the Affordable Care Act, ACA, back in March 2011, provides crucial clarity and a guiding national framework. It offers guidance on how healthcare providers and delivery systems can meet those interconnected national goals we talked about, improving the individual patient experience, enhancing population health, and decreasing overall healthcare costs. The triple aim, essentially. With input from over 300 diverse stakeholders, the NQS's ultimate aim is to provide a comprehensive framework to help align quality measures and quality improvement activities across the entire U.S. healthcare system, creating a unified vision for excellence.
Trying to get everyone pulling in the same direction on quality.
Exactly. And as anesthesia practice stands at what our sources call a new crossroads, patient satisfaction, as a measurable outcome of health and delivery experience, has truly emerged as a valuable metric in this evolving system. It wasn't always seen that way. The profession has been undergoing significant changes, and our sources emphasize that in the future, roles and responsibilities within anesthesia could even be called into question, and the sustainability of the practice model could be in jeopardy if the focus doesn't continue to evolve towards these new value-based metrics. Remodeling practice, therefore, represents what Clayton Christensen might call a disruptive improvement, offering benefits that are simpler, less costly, and often of equal or even higher quality than existing, more complex fee-for-service models. The critical link here is that clinical practice effectiveness and patient outcomes will become an even more important measure of success as the ACA and other reforms continue to tie payment directly to high-quality care, population health improvements, and reduced healthcare expenditures. It's fundamentally shifting from a volume-based system, do more stuff, to a value-based system, get better outcomes efficiently.
The value equation. Outcomes over cost.
Precisely. The nurse anesthesia community has been provided with extensive resources, articles, studies, books, all highlighting the historical need for patient-centered healthcare, particularly for communities of color who have faced significant disparities. The evidence is clear. Patient-centered care demonstrably improves disease outcomes, enhances quality of life, and is absolutely critical for addressing racial, ethnic, and socioeconomic disparities in healthcare. That influential National Academy of Medicine's Crossing the Quality Chasm report defined patient-centered care perfectly as care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. It's worth noting, too, that shared decision-making isn't actually brand new in anesthesia practice. It has historically been a hallmark of the profession in many ways. Anesthesia practice has often involved a form of shared decision-making by including physician generalists, physician specialists, nurses, and auxiliary personnel throughout the perioperative experience. The success hinges on clinicians and patients sharing the best available evidence to make informed decisions. The use of interdisciplinary teams is an essential element in developing quality care measurements, and achieving consensus among appropriate stakeholders ensures that those crucial risk-benefit trade-offs are thoroughly evaluated for each patient.
Okay, so the philosophy's there. But beyond just the quality of care itself, how do these complex measures and reporting requirements tie directly into financial incentives and, ultimately, reimbursement for providers and institutions? Because understandably, that's a huge driving force in how healthcare operates.
It's a crucial link, absolutely. It connects quality directly to financial sustainability for practices and hospitals. While any organization, public or private, can technically develop a quality measure, gaining broad organizational and provider buy-in is paramount for health plans and payers to actually endorse and use them for payment. Currently, the National Quality Forum, NQF, stands as the leading independent organization in the U.S. that reviews and endorses healthcare quality measures. The NQF is a nonprofit, nonpartisan, membership-based organization. Their endorsed measures and standards form a critically important foundation for initiatives aimed at enhancing healthcare value, making patient care safer, and achieving better health outcomes nationally. Their endorsement process is designed to be transparent and consensus-based, bringing together diverse healthcare stakeholders from both the public and private sectors to foster quality improvement collaboratively. At the time of the source writing, approximately 300 NQF endorsed measures were in use across more than 20 federal public reporting and pay-for-performance programs, like those run by CMS, as well as in various private sector and state programs. That demonstrates their widespread influence.
So NQF endorsement is kind of the gold standard for quality measures.
It's certainly the main pathway for measures to be used in major federal payment programs, yes. And the anesthesia professions are often cited as leading the way in patient safety and outcomes, proudly setting an example for safe, high-quality care in many respects. Significant reductions in anesthesia mortality, as we discussed, have been accomplished through a combination of using new technologies, standardizing processes, employing simulation for training and teamwork, championing patient safety and quality initiatives, and the formation of foundational organizations like the Anesthesia Patient Safety Foundation, APSF. Beyond just anesthesia, the broader National Patient Safety Foundation, NPSF, now part of the Institute for Healthcare Improvement, IHI, also plays a vital role, born from the idea of a collaborative initiative involving all members of the healthcare community to stimulate leadership, foster awareness, and enhance patient safety knowledge across the board. The American Association of Nurse Anesthetists, AANA, is continuously developing informational sources and tools to aid CRNAs in understanding the complex relationship between quality and value as outlined in many of the CMS quality initiatives. These initiatives directly affect reimbursement, making it essential for CRNAs to build their knowledge base and become intimately familiar with them to ensure fair payment and demonstrate their value. A key example is the Physician Quality Reporting System, PQRS program, which has evolved over time but established the principle. This was a CMS quality initiative that directly affected eligible providers, EPs, reimbursement rates for covered Medicare Part B fee-for-service, FFS, beneficiaries based on reporting quality data. While technically a voluntary program initially, non-participation carried significant financial implications for future Medicare Part B FFS reimbursement in the form of payment adjustments or penalties.
So voluntary, but not really optional if you wanted full payment.
Exactly. Compliance with PQRS reporting requirements had repercussions even beyond the PQRS program itself, making understanding it essential for safeguarding Medicare billings. There were several PQRS reporting mechanisms available for practitioners, depending on their specialty, setting, and practice capabilities, things like claims-based reporting, using electronic health records, EHRs, reporting through a qualified registry, or using a qualified clinical data registry, QCDR, or participating via a group practice reporting option, GPRO. Lots of acronyms, but important mechanisms. With the passage of the Patient Protection and Affordable Care Act, there's been that increased demand for healthcare providers to accelerate quality improvement and promote transparency through clinical quality measures reporting. CMS, through various evolving quality reporting programs like MAEPIS, Merit-Based Incentive Payment System, which replaced PQRS, collects numerous metrics, including performance measures and patient experiences. They now use these to publicly report on healthcare provider and group practice performance. Notably, qualified clinical data registries, QCDRs, that specifically support anesthesia measures are available, often through professional organizations like the AANA, further streamlining compliance and quality improvement efforts tailored to the profession. It's all interconnected. Safety leads to quality, quality is measured, and measurement increasingly impacts payment and value demonstration. Hashtag tag tag outro.
So what does this all mean for you, the listener? We've truly taken a deep dive today, haven't we? Uncovering the intricate layers of patient-centered care, cultural competence, and their profound impact on the future of healthcare, particularly in a field like nurse anesthesia. It's a complex, but I think ultimately hopeful, picture of transformation that's underway.
We've seen that viewing the patient as a unique individual with distinct attitudes, values, beliefs, and behaviors is not just, a kind gesture or good bedside manner. It's a necessary component for providing truly high-quality, safe, and effective care. It's fundamentally about recognizing individuality and striving to create an environment free of discrimination, regardless of race, national origin, color, age, religion, sex, including pregnancy and gender identity, sexual orientation, disability, status as a parent, genetic information, or any other factors. It's about tailoring care respectfully to the whole person.
Yeah, this deep dive has really highlighted that transforming healthcare isn't just about the next groundbreaking technology or new miracle cure, as exciting as those can be. It's about fundamental shifts in philosophy, in organizational culture, and in the details of daily practice, all aimed at putting you, the patient, truly at the center of every decision, every interaction. It's a profound reorientation.
Which this raises an important question for all of us, I think. Whether we are patients ourselves, family members navigating the system for loved ones, or healthcare professionals working within it. As you reflect on all this information we've unpacked, maybe consider, how can each of us actively contribute to a system that consistently delivers truly patient-centered, culturally competent, and equitable care for everyone? What's maybe one tangible step you might take to foster this kind of environment in your own sphere of influence? Whether that's asking a more informed question at your next doctor's appointment, or perhaps advocating for better training or resources if you work within the system. Something to think about.
That's a great closing thought. Thank you for joining us on this deep dive into the heart of healthcare transformation. Keep learning, keep questioning, and keep advocating for the best possible care for all.